Welcome to OsteoBytes, everybody. My name is Anne Graham, and I'm the Executive Director at MIB Agents. Today on OsteoBytes, we are talking with Dr. Katie Janeway to get an update on an OSI-funded phase 2 trial of Olaparib Ceralasertib in recurrent osteosarcoma. Thank you so much to Dr. Janeway for joining us on OsteoBytes today. Super thrilled to have you, especially to talk about something for recurrent osteosarcoma. And thank you to Max for joining today. Max is an OsteoWare, and he's also an MIB Agents Junior Advisory Board member, which is a very important part of MIB Agents. So thanks to you, Max. A little bit more about our guest today. Dr. Janeway received her medical degree from Harvard Medical School in 2000. She subsequently completed her residency in pediatrics at Children's Hospital Boston. She was a chief resident at Children's Hospital Boston and then completed her fellowship in Pediatric Hematology-Oncology at Dana-Farber Cancer Institute, Children's Hospital Boston. In 2007, Dr. Janeway joined the staff at Dana-Farber and Children's Hospital Boston, where she is a pediatric hematologist-oncologist and investigator with a research focus on pediatric sarcomas. Thank you so much for doing that. She also serves on MIB Agents Board of Directors and on our Scientific Advisory Board, and will be a speaker at MIB Agents Factor Conference in 2 weeks. It's coming up so fast. That's right, June 23rd to 25th in San Diego. If you aren't already planning to attend, it's not too late. We have a few seats left for the general session, which features 50 expert speakers in osteosarcoma. New this year, we have added a wellness track. This is going to be amazing. It includes really cool programming like sound bath, which is not an actual bath at all. You get to keep your clothes on. It's just a immersive sound experience that is really cool. Super excited about that. We also have healing touch, reflexology, painting classes, flower arranging, wellness walking, like so many great sessions. These may be of particular interest, well, who wouldn't be interested, but to families who have a child in treatment or who have lost a child to osteosarcoma who's attending, and you might need a break from the scientific sessions. If you cannot attend in person, by the way, you can attend the scientific sessions virtually, which will give you a live stream and on-demand access to the scientific sessions. Nothing beats the energy of being at Factor in person, connecting and interacting with colleagues, patients, families, but virtual is a great alternative if you can't make it to San Diego this year. There's also a Healing Hearts retreat on Sunday. This is provided at no charge for families who have lost a child to osteosarcoma. And finally, if that's not enough, there are also going to be tacos and beer and craft root beer and karaoke at Hess Brewery Seaport on Thursday. All are welcome. Unless you can't sing, then please stay home and don't come karaoke. Just kidding. Just kidding. I can't sing either, so bring it in. All right, this episode is sponsored by the Osteosarcoma Institute, OSI. It is a nonprofit led by osteosarcoma experts from top US cancer centers who together are concentrating on the cure for osteosarcoma. The mission of OSI is to dramatically increase treatment options and survival rates in osteosarcoma patients through identifying and funding the most promising and breakthrough osteosarcoma clinical trials and science. In addition to advancing research, and this is so good, you guys, really, OSI provides a free resource called OSI Connect. This is for osteosarcoma patients and their families. The osteosarcoma experts at OSI can discuss available treatments, possible side effects, provide helpful advice for getting to the most out of your visits with your treating physician. This resource is available in English and Spanish, and aims to help patients and families find answers to their questions. It's absolutely brilliant. We'll put some information on how to get connected with OSI Connect in an email after this session is completed. All right, Max, would you introduce yourself, please?
Hi, my name is Max. I'm 17 years old and from Long Island, New York. I was diagnosed with osteosarcoma when I was 10 years old in 2015 and went through treatment for almost half a year at New York Presbyterian. I'm currently a high school junior and part of the MIB Junior Advisory Board. I'm also a trained ambassador agent.
I'm thrilled to be here today for Osteobites. And thank you very much for that very kind introduction. And I have presented this trial once before, and we're really excited to be able to provide an update. So what I'm going to speak about today is a phase 2 trial of Olaparib in combination with Ceralasertib in patients with recurrent osteosarcoma. I am presenting, but I want to point out that my colleague, Suzanne Forrest, who is one of the younger faculty members here at Dana-Farber and Boston Children's, has really worked hard with me to develop this trial and also takes care of the patients who come to Dana-Farber to enroll on this trial. And so you may hear her name in association with this trial as well. So I have an agenda. I'm actually going to start with a trial overview and status update. So for those of you who've sort of heard a lot about this trial before, I'm going to provide you some updates just in the first 2 slides, and then you can zone out a little bit, because then I'll go back into a reminder of why we're doing this trial. I'll talk in more detail about the trial, what our goals are, how it is designed, which generally means like, what questions is it going to answer? The inclusion criteria, which means who's allowed to come onto the trial, what are our sort of criteria for that, the treatment that we're delivering, some potential side effects of that treatment, and then what we're calling correlated biology. In other words, how are we going to learn from this trial, regardless of what the outcome is? And also, I think people can enter questions into the chat. I'm going to be here after I finish presenting to answer questions. But if somebody, Anne or Max, if someone enters a question and you want to interrupt me, please feel free to do that. I actually can't see anything but my slides, so you'll have to just speak up. This is a phase 2 trial. Like I said, what that means is that we're trying to determine how well this therapy works in osteosarcoma that's come back. In other words, we've already figured out in adults what dose of Olaparib and Ceralasertib is safe and what the likely side effects are. And now we're trying to put that dose of those medications into patients with osteosarcoma to figure out if this treatment works. That's what a phase 2 trial means. Every patient who enrolls on this trial will get those 2 medications. So just as an overview, like I said, I'm the lead investigator and Suzanne Forrest is my lead co-investigator. There are 4 enrolling sites: Dana-Farber / Boston Children's, MD Anderson Cancer Center, Memorial Sloan Kettering, and University of California. We're doing a lot of work along with this trial in the laboratory. We call those correlative studies. And Dr. Alejandro Sweet Cordero at UCSF will be working on those. Our sponsor, that means who's actually supporting the trial in terms of funding, is Osteosarcoma Institute. AstraZeneca, who make Ceralasertib, are providing both of these drug medications. And we received the drug from a company called McKesson. In terms of the trial status, the trial is open or has been activated, and you have to wait till the very end to hear the very latest status, but I just want you to know it's been activated at Dana-Farber, Memorial Sloan Kettering, UCSF, and not quite yet at MD Anderson Cancer Center. It's really the lawyers that are holding us up there, and we're working on that. I think the last time I spoke, it was only open at the Dana-Farber Cancer Institute. One thing you'll learn is that it takes time actually to get trials sort of up and running at each institution. As we've been enrolling patients, or patients have been entering onto this trial, and at Dana-Farber, we've had 6 patients total enter onto the trial, and I'll talk to you a little bit more about what the difference is between those 2, cohort 1 and cohort 2. We've had 6 patients enroll, but as patients have been enrolling, we've actually learned some information from ongoing trials of Olaparib and Ceralasertib. The first thing is that there is some activity of this drug combination, but we're not seeing as much or activity for as many patients as we would like. And let me show you what I mean. So this is actually very recently presented data from ASCO, the ASCO annual meeting in 2022, which I just came back from. It was last weekend. And these are patients with breast cancer who are receiving Olaparib and Ceralasertib. And the response rate, the response rate is the number of patients who had their tumor shrink compared to all the patients who entered the trial. Those responding patients are shown here in blue. This is what we call a waterfall plot. So this is the measurement of the tumor, with 0 representing no change from the measurement of the tumor when the person entered the trial, with negative 100% means it went completely away. And then on this side are individuals whose tumor grew. So each one of these bars is a patient. And so what you see is that all of this blue are patients who responded to the combination of the drugs. Some other people had tumor shrinkage, but we don't count it because it's not enough tumor shrinkage, okay? And basically what you're seeing is there are patients responding. It's about 17% of patients who enrolled, but it's not quite as high as they were hoping for or looking for. So why might that be? So it turns out that as we do these trials, we actually measure how much of the drugs are in the patient's system, in the body system. And with the dosing of Ceralasertib that's been used, there's a lower concentration in the blood than they saw have its good results in the laboratory. So when they treated cells, for example. So basically, I mean, this is detail that you don't really need to know, but they want to see about 180 hours of drug exposure per cycle, and patients are getting somewhere around 120 hours. And there's another study called the Violette study, which is in breast cancer also. And here they also see activity. They see a prolongation of progression-free survival with the 2 medications, Ceralasertib and Olaparib, compared to Olaparib alone. But again, not quite as much increased duration of tumor control as they would like. Data emerging says that there's a safe alternative to the dosing strategy we originally used. And so the sort of trial status as a result of all of that is, after we enrolled 6 patients, we learned this information. We were really happy that there's signs of activity of these 2 drugs together in the types of scenarios that osteosarcoma has. But we also recognized that we wanted to put our best foot forward in this trial. And so we stopped enrollment to the study. We updated the dosing strategy, and we're now activating the trial again. So that's kind of a high level update. I think you'll get, now I'm going to go into the details. Okay. So first, this is the first slide on why are we doing this trial? What made us want to study these drugs in osteosarcoma? So this blue, dark blue and light blue thing up here at the top is DNA. And DNA is just sort of a series of letters. And when your cell divides, you have to duplicate the DNA. So each one of these strands, one is from the mom, one's from the dad. So each cell in your body has 2 strands of each of the strands of DNA. And there are many, many strands in the body. These 2 separate, get duplicated, and then get passed on to the next cell. Turns out that when you do that, there are all kinds of problems that can happen. You can have a typo, you can have a break in the DNA in one of the strands, that's called single strand break, and you can have double strand breaks, that's called double strand breaks. And so there's all this machinery in the cell, which is what all of this picture is down here, that repairs those breaks. The most commonly known genes that repair those breaks are the breast cancer genes. Those are what we call BRCA1 and BRCA2. And people who are at risk for breast cancer have these genes are abnormal or dysfunctional in all the cells of the body. It turns out that you can get dysfunction of these types of genes only in the tumor cells, meaning not in all the cells of the body. When you have dysfunction of what we call homologous recombination, you need to use alternative repairing of these breakages. And that results in something called signature 3, which is a pattern of changes in the DNA that are a scar from what we call a defective DNA damage response. So breast cancers, where the BRCA genes are abnormal, have this signature 3. Olaparib, Yes, please, go ahead.
Sorry, I didn't want to interrupt this last slide, but on the slide before, there's a question from an attendee on the trial status. On that trial status graph, is that for osteosarcoma patients only, or for other trials as well who are using the same drug combination?
You mean changing the dosing?
Just in general, is this for, does
this chart here, so the trial we're running is only for osteosarcoma patients. So there are no non-osteosarcoma patients on our trial. So this active chart here is for osteosarcoma patients only. If you're asking about changing the dosing, that is the case for any trial that's being run with Olaparib and Ceralasertib is changing to this updated dosing strategy.
Okay, got it. That makes sense.
Does that help?
Yep, that's it.
Okay,
thank you.
Great. Okay, so so the reason that this matters is that Olaparib is FDA approved for the treatment of breast cancer, ovarian cancer, and pancreatic cancer with BRCA mutations, either as a first, second line therapy or as maintenance therapy. And it works because of that defective DNA damage response. So it's what we call a targeted therapy. So what happens is if this BRCA1 or 2 or any of these other machinery items are not working, you become reliant on a different pathway to repair things. And one of the things you become reliant on is PARP. And Olaparib, which is right here, is a PARP inhibitor. So if you knock out this and this, you end up not being able to repair those breakages in the DNA, and the cell kind of falls apart. It can't survive. It can't replicate. So Olaparib is FDA approved for breast cancer and ovarian cancer. It's an oral medication, and it has sort of a lower incidence of many of the chemotherapy side effects, although a higher incidence of anemia. Okay, and it basically causes either a large proportion of patients like this to have tumor shrinkage, or if you look at sort of progression-free survival, which is how quickly does the tumor progress, it sort of delays progression. But osteosarcoma, I'll show you in a minute how this relates to osteosarcoma. Osteosarcoma doesn't have BRCA mutations for the most part. It doesn't have the breast cancer gene mutations, but there's a set of breast cancers that have signature 3 and no BRCA gene mutations. Those are the ones shown in red, and we call those BRCA-like, who are also helped by Olaparib. Okay, that Olaparib also works in those patients. So what about osteosarcoma? So it turns out that osteosarcoma has signature 3. So this is data from our own institution. This was analyzed by someone named Amanda Marinoff. And of 92 osteosarcoma samples from higher risk patients, meaning the cancer was metastatic or it had already come back, about 30% have signature 3. But we actually don't see those underlying BRCA mutations and other things that you tend to see in in breast cancer and ovarian cancer. So the cause of this is not very well understood in osteosarcoma. So that's our own data, but actually, and we like to see this in more than one study to sort of plan a whole clinical trial around it. So it turns out there are 2 other studies of pediatric cancer that look at osteosarcoma and whether or not there's signature 3. And here again, each patient is kind of a bar, and the more orange it is, the more signature 3 is in that cancer sample. And so here, about 50% of the osteosarcomas have a good amount of signature 3. And then similar here, actually, they also show it in orange. This is a good proportion of osteosarcoma patients, again, about half who have signature 3. And then this is actually from a sort of national database of cancer types. So it goes across not only childhood cancer, but also adult cancer, and looks at the proportion of patient samples that have signature 3. And this one's a little bit harder to read, but I've sort of typed out the proportions here. So in bone osteosarcoma cancer, about 1/3, similar to our data, have signature 3. And if you look at the other diseases where Olaparib is actually becoming a really important part of treatment, you can see that breast cancer, pancreatic cancer, ovarian cancer, and prostate cancer have, similar proportion of cases that have signature 3. And so we sort of said to ourselves, why are we not studying Olaparib in osteosarcoma? And that sort of was the origin of the decision to study Olaparib. But osteosarcoma, even compared to those cancers I just talked about, is very aggressive. And we were worried about using Olaparib all by itself. We wanted to add something to Olaparib. Well, it turned out that in breast cancer and pancreatic cancer, they also are interested in adding something to Olaparib to make things work better. And so one of the drugs that was being evaluated is this Ceralasertib. So to tell you about why Ceralasertib is of interest in osteosarcoma, I need to talk about telomeres. So when you take all the DNA and in all the in all of the cell, the cancer cell, and you sort of condense it down, it goes into what's called a chromosome. And the chromosome, it gets sort of packaged into a chromosome. The chromosome has an end to it called a telomere. And telomeres get shorter over time. Actually, as you age, all the telomeres and all your cells in your body are getting shorter. It's part of what actually causes aging. And if a cancer cell doesn't have a way to keep the telomeres long, it will grow old and ultimately die, just like people do, because their telomeres get short and they grow old. So a cancer, to sort of stay alive and keep dividing, needs to keep its telomeres long. And they use an alternative way of doing that. In other words, they create their own sort of special way, which is called ALT, or alternative lengthening of telomeres, to keep their telomeres long. And it turns out that about half of osteosarcomas have this alternative lengthening of telomeres that they're dependent on to stay alive. And osteosarcoma cell lines with this ALT are sensitive to a group of drugs called ATR inhibitors, and Ceralasertib is an ATR inhibitor. So what about putting the two together? And as I said, there was a lot of interest in doing this, and it had been studied in pancreatic cancer, in lung cancer, and in ovarian cancer. And in fact, there had already been a clinical trial combining these two chemotherapy medications, which is where we got our initial trial dose, because we understood that it was safe to give, and it was, we knew sort of what some of the side effects might be. Now, and a very important point is that this trial, which is called a phase 1 trial, where you figure out the dose and what the side effects are, was done in adult patients. And so what that means is we can extrapolate from this for anyone who's 12 and older, and anyone who has a reasonable body weight, which for us is about 40 kilograms. Also, as I mentioned in the sort of study status update slide, they had tried, there are some other trial doses that have been studied in phase 1 in adults, and this is the new trial dose. So in the new trial dose, because the goal is to sort of maximize that Ceralasertib exposure, we're giving it for longer, but in order to do so without too many side effects, we're also slightly we're cutting in half the Olaparib dose. So the Olaparib dose is coming down from 300 milligrams to 150. And the Ceralasertib dose, the daily dose, we're giving the same dose per day, but it's given twice a day, and it's going for longer. So sort of half of the cycle. The cycle is 28 days long. So now let me talk about our goals. So what are we trying to accomplish here? The first is to test whether these two drugs work together to treat osteosarcoma that's come back or been resistant to treatment. And the second is to collect tumor and blood samples to understand which patients benefit from this treatment to advance osteosarcoma research or our understanding of osteosarcoma. We are treating two groups of patients. We call these cohorts. Group 1 is osteosarcoma that's measurable and not able to be removed by surgery. So that's like a patient with a lump of tumor. And there are 19 total patients who would be enrolled with that type of osteosarcoma. Group 2, or what we call cohort 2, is osteosarcoma that for at least this recurrence is only in the lung, and is able to be removed with surgery. And that is, we have actually no limit on that number of patients, except for that when we finish with the 19 patients in group 1, we're not accepting any more group 2 patients. So what will we know at the end of the trial? So the first point is really, does treatment with Olaparib and Ceralasertib prolong progression in recurrent osteosarcoma? So we have a pretty good sense of how quickly osteosarcoma moves in patients, or how quickly it progresses without effective treatment. And unfortunately, that is quite quickly, that this is if you have a measurable lump of tumor. I just want to be clear about that. Unfortunately, that's pretty quickly. And so what we're looking for, again, we're treating every single patient, and we're basically going to look at how quickly the osteosarcoma moves in those treated patients on this trial, as compared to sort of what we already know happens in this disease when there isn't effective treatment. The second thing that we're trying to learn is, are we able to collect tumor material from before and after treatment with Olaparib and Ceralasertib to help us better understand which patients with this in which patients will this treatment be most effective. And so this little picture I'm showing you down here is the kind of thing that we hope to do in osteosarcoma. So this is from that I showed you at the beginning on the trial status update, that there's this nice trial in breast cancer patients now that was presented at ASCO, showing that the treatment works in about, causes tumor shrinkage in about 17% of women with breast cancer. Here they look at different subgroups of women with breast cancer, and they looked at BRCA mutations, something called ATM, something called, which is lost also in osteosarcoma, by the way, something called cyclin E, and there are osteosarcoma patients with high cyclin E in the tumor. And then something called RAD51, and RAD51 is kind of like a readout of how defective your repair machinery is. And what you can see here, they're showing sort of how much response, like how many of the patients with each of these groups had a response to Olaparib and Ceralasertib, and the RAD51 low patients, 67% of them had tumor shrinkage with this combination of drugs. And so these are the type of information that we're really hoping to generate, and we're doing it with the tumor material that we're collecting. This is just a very fancy diagram of how the clinical trial, which is over here on the right, and I'll walk you through it in just a second, is sort of intimately linked to the biology work that's going to be performed in Dr. Sweet Cordero's laboratories. So I'm going to walk you through the trial really quickly. So a patient presents for the trial. We obviously have to make sure that they are eligible, which I'll get to in a couple slides. If they're eligible, and they enroll in cohort 1, which is where the tumor is very large in a place in the lung, for example, where it can't be removed, or anywhere else in the body, they'll get Olaparib and Ceralasertib, and they will have their disease evaluated. For these patients, we require that there is a tumor sample that can be submitted to Dr. Sweet Cordero's lab, so that he can study things like RAD51 and cyclin E, and whether or not they're associated with having a better effect of the drug. For patients in cohort 2, which means they have lung-only disease that can be resected. If the disease is only on one side, they also need to have tumor material that can be submitted. They enroll from before, any other time before that's been taken out of their body for any other reason, like biopsy or surgery. They enroll, they get 2 cycles of the medications, they are evaluated, the tumor is resected, and that tumor is submitted to the Dr. Sweet Cordero's laboratory, and he will grow a model of the tumor so that he can do some very sophisticated studies, like really produce a lot of the tumor material to be able to do very careful sequencing analysis, but also to sort of treat with additional drugs and drug combinations, just in case this isn't the best drug combination, so we can sort of be ready to plan the subsequent trial. For patients with bilateral metastases, they enter the trial, have the first side resected, get 2 cycles of the drug, and have an evaluation and have the second side resected. So what are the criteria for entering this trial? Patients need to be aged 12 to 40, weigh 40 kilograms, have tumor tissue from previous surgery available for testing, surgery or biopsy. These medications are pill medications, so people need to be able to swallow pills. The blood counts need to be at a reasonable level. And for cohort 2, they need to have not had their surgery already. So we're trying to enter patients before surgery so we can collect the tumor material on the trial. So what treatment is administered? We provide all of the treatment through the trial. It's actually, you can get Olaparib outside the trial, but we administer it. We have a drug supply with the trial. Olaparib is given twice a day for 28 days, and Ceralasertib is the 80 milligrams twice a day for the first 2 weeks of the trial, of the cycle. We monitor for side effects and we adjust doses if needed. Participants can remain on treatment for up to 2 years. I described the lung surgeries that will occur at designated times. What about the potential side effects? So we've treated, as I said, 6 patients on this trial. We haven't seen really any unexpected side effects. I think the common things are nausea. Generally, people have to take Zofran during the 14 days when the Olaparib is being given. Once the Olaparib is done, the nausea tends to go down some. Anemia, I don't think we've actually had to give blood transfusions on this trial, but we have seen some decreases in the number of red blood cells. This medications can also slightly decrease platelet and neutrophil counts. I've only had one patient where the platelet count has been quite low, and that was probably because of another medication that was being taken at the same time that also lowers platelet counts. Beyond that, we really have not seen much in the way of other side effects, but there are some rare side effects that can happen. And obviously, if someone is coming for this trial, we would go through those side effects with you in a consent discussion. So now to the real current status. The amendment means the new dosing strategy. And so to enter onto this trial now, each site needs to have the amendment open so that we're giving the right dosing strategy. So that amendment is active at Dana-Farber. We are able to enroll patients on the trial with the new dosing strategy. At Memorial Sloan Kettering, they're working on opening the amendment. It will be several weeks. At UCSF, it's probably going to open sometime mid to end of July or maybe early August. And at MD Anderson Cancer Center, it's a little bit hard for me to estimate because we have these lawyers going back and forth, and I'm unfortunately not in control of their decisions and their negotiations. So with that, I just want to acknowledge Suzanne Forrest, who's worked incredibly hard on this trial, Alejandro Cordero, who is our laboratory collaborator and will really show us the path forward after this trial is complete, whether it's successful or not successful. And we really feel that's so important. It will allow us to learn from every single patient who enrolls on the trial to help us sort of see where we go next in this whole group of drugs that address this DNA repair problem, which osteosarcoma definitely has. And we really have to figure out how to leverage that to sort of move forward and bring new treatments to the disease. The sites that are enrolling the patients, our statistician is Wendy London. Our study coordinators are Grace Fairchild and Amy Opara, who actually are, I think, Grace is our associate research manager, and Amy is our clinical research coordinator, and Carrie Kavanaugh, who's our research nurse at Dana-Farber. These are Dana-Farber individuals. And with that, I think I'm going to stop sharing and answer any questions.
So many questions. Go ahead, Max.
Oh, there's one in the chat. What is the longest time that an OS patient has been given this treatment out of the 6 patients who seem to be on the trial currently?
Yeah, that's a great question. A really important question. I'm going to answer that question, but I'm going to answer it in a slightly different way. So one question that people often ask us when they come for trials is how is it working? Like, what do you know about, is this treatment working? And when we design trials, we design a trial to enroll a certain number of patients to tell us the answer to that question, is it working? And because every patient is different, every patient's tumor is different, and every patient's response is different. So we need to look at the overall group of patients once we have all 19 patients enrolled, in order to answer the question that you're asking me, you're sort of trying to get at the question, is this working? And I can't answer that question until all 19 patients are enrolled and we have some time after they're all enrolled to sort of follow along and see how they do. So I can't answer that question because it's too early for me to be able to tell you. It's everybody asked me that question. It's a really good question, but it doesn't help us to look at 1 or 2 patients and how much medicine they got.
Any flexibility on the weight restriction, and why is there one?
Yeah, that's a great question. So the age and weight restrictions are sort of, I guess what I would call regulatory restrictions. So, one of the ways that we've been able to move some drugs quickly into osteosarcoma phase 2 trials. Let me back up. I am a great proponent of aggressively moving drugs quickly into phase 2 trials in osteosarcoma patients, because it's fairly unacceptable that we don't have any new medications really in so much time. So for standard trials for young people with cancer, to move to a phase 2 trial, which is what we're doing, only one disease, does the drug work? You first need to do a phase 1 trial, which is to study the dosing in young people less than 12 and less than 40 kilograms. So for many pediatric childhood cancer diseases, we need to do those phase 1s first. We have argued that we should skip the phase 1 trials and move straight to phase 2 trials, because most of the patients, not all, unfortunately, but most of the patients with osteosarcoma that's come back, which is where we study these new drugs, are over 40 kilograms and 12 years or older. The FDA allows us to study new drugs in patients who are 40 kilograms or greater and 12 and over, without doing the phase 1. And phase 1s take quite a while, because when you do a phase 1, you basically treat 3 people, wait and see what their side effects are. Then you open the trial to the next 3 people, wait and see what the side effects are. Sometimes you have to increase or decrease the doses and then wait more. So they take like 2 years to finish. And so what we've done is to say we want to take drugs from being, or drug combinations from being studied in adults and figuring out what the dose and safety is, and take them right to osteosarcoma patients if there's a reason to study them in osteosarcoma, like there is here. The unfortunate consequence of that is that it's only safe to treat the patients who are adult-like, and meaning their metabolism of drugs, the side effects of the drugs is adult-like. And the patients who are adult-like are 12 and older and 40 kilograms and bigger, because most adults, it's rare. Like I always, when I'm arguing with people, mostly pharmaceutical companies who are slowly coming around to this idea that they can go straight from an adult trial to what we call adolescent young adult trial, which is what we do in osteosarcoma. I say, picture the frailest, old lady with breast cancer, right? She's going to weigh about 90 pounds, right? That's the same as a smaller 12-year-old. So that's how we got to this 40 kilogram weight, is that's the weight and the age at which we can sort of extrapolate the adult phase 1 trial down to. Now, if this works, if the phase 2 trial is what we call positive, then we must study this dosing strategy in younger patients so that we make sure that it's available for all osteosarcoma patients.
Do you have any thoughts on other osteosarcoma trials in the United States? And
Yeah.
Do you have plans for possible research in Europe?
Okay, so that's a great question. So there are a number of other I almost put a slide in, so I'm really glad somebody asked that question. There are a number of other interesting osteosarcoma trials in the United States. So there's a trial ongoing right now of a combination. It's being conducted by the what we call the CITN, which is a cooperative group of hospitals that are funded to study immunotherapy in different cancers. And there's a trial of dinutuximab, which is an antibody that's used in neuroblastoma, a different childhood cancer, and we studied it in osteosarcoma and it didn't work, but a very talented laboratory investigator at Stanford did a study in mice where he showed if you add another drug, which is called an anti-CD47 antibody, to this dinutuximab, that it might work in mice better than the dinutuximab alone. So that trial is open and enrolling patients. There's a long wait list for that trial, but it will have, similar to our trial, it will have options for patients who are fully resected or patients who have a lump of tumor for osteosarcoma. It's right now in a safety phase. So it's kind of taking, it's that phase 1 part that I told you about that takes a long time. And generally it's hard for osteosarcoma patients to get onto because those phase 1 trials often have long wait lists. And as I said, when osteosarcoma comes back, especially if there's a lump of tumor that can't be taken out, things tend to move quickly and it's hard to sit on a wait list for 3 or 4 months. So right now that trial has wait lists, but once it gets past the safety phase, there will be osteosarcoma specific spots for our patients. Okay, so that's one trial. There's an ongoing trial of it's a novel immunotherapy that's was studied in dogs. It's a trial being developed by OS Therapies. And it's for patients who have lung-only relapse. It has to be, I think, the first or second. The tumors are removed from the lungs, and then this is given. It's once every 4 weeks. It's an IV administration of kind of it's a bacteria, modified bacteria that's supposed to activate your immune system. That's an exciting trial. These are the ones that are just coming to me off the top of my head. There are other phase 1 trials testing new drugs that might be relevant to osteosarcoma. So yeah, there are a lot of interesting trials. We have many of these trials and other trials open at Dana-Farber. So, and at many of the other institutions that I talked about. So yes, there are a lot. And then there are nice trials also being developed in Europe as well. But I don't know those as well, sort of off the top of my head, because I don't practice there.
By the way, if you go to MIB Agent's website, we have a clinical trial search where you can find an osteosarcoma specific clinical trial connected to clinicaltrials.gov in under 60 seconds. And it's really cool because it also, once you're in the system, they'll keep updating you when a new trial becomes available. It's really amazing. If you've ever been on clinicaltrials.gov and tried to wade through all of that, you know how cool it is to find something in under 60 seconds. Okay, another quick question on also from Europe. The question really is around what are the criteria to decide when a trial is most hopeful? Like when are you there on a trial?
Yeah, so in general, let me talk about some generalities. So let me talk about phases of trials again, just in terms of the response to this question. So a phase 1 trial is a trial of how do we give a drug and like what dose and what are the side effects. In general, a phase 1 trial, you should think of it as, I am doing this to help future cancer patients. Okay, for the most part, phase 1 trials are not specific for osteosarcoma patients. We don't have a lot of information to tell us this is a very interesting thing in osteosarcoma. Okay, so that's a general statement. There are some exceptions, like the trial I just told you about with the dinutuximab and the anti-CD47. Yes, it's a phase 1 trial, but that phase 1 trial is restricted to neuroblastoma and osteosarcoma because we have some information in those two diseases. But in general, a phase 1 cancer trial is about, it usually is like all comers with a solid tumor, and it's about finding the right dose and learning about the side effects, which is that. Now, I love phase 1 trials, don't get me wrong, and there's some really interesting new drugs out there. And when we select a phase 1 trial or explain a phase 1 trial, we usually select the ones that we think are most interesting in your disease, but they're not specific to that disease. A phase 2 trial we move into either because it's, again, testing a specific drug in a specific disease. How long does it work? How well does it work against a cancer? We usually move into that either because in the phase 1 trial, we saw a little bit of activity of that drug in a specific cancer, or because we have a specific reason to think it might work in that disease. And those reasons come from the laboratory for the most part. They come from people studying drugs in models of the cancer, meaning a cell line that's sort of growing in a dish or in a tumor that's growing in a mouse. I was talking about this the other day with someone, actually the parent of a patient of mine, who asked me about, they say this drug is promising. What does that mean? Research scientists and people like me who then take their research from the laboratory and develop it into clinical trials, we're a little messy with our language. And we use this word called promising, which means I have some nice study in the laboratory. I've seen it. It shrinks a lot of the tumors in the mice, or it kills a lot of the cells growing in a dish. That's promising. That doesn't actually, it just means I'm interested. I'd like to study this more. I think we should do a clinical trial. I think we should learn whether or not it works in people. That's when you would do a phase 2 trial. But promising, I think, is misleading, because the truth is that we really can't, many of the drugs that look good in the laboratory, all cancers, not just osteosarcoma, don't end up working in patients the way that we expect, or as much as we expect, or with as much promise as we see in the laboratory. Some of them do, for sure, but not all of them. And that's why we need to do the clinical trial. And we haven't figured out kind of what criteria from the laboratory studies, how to rank them. Do you know what I mean? Like which ones are more likely to succeed than others? But yet we throw around this word promising as if we understood somehow how that laboratory information is going to translate into how well it works in the patients when we do the phase 2 trial. So it's a really, really good question. I wish I had that. What I'm trying to tell you is I don't have the answer to it. Like I can't tell you. Once you see a phase 3 trial, that's where we're often trying to bring something to become sort of standard of care. That really, then I think we should use the word promising, because what that means is that we saw something in phase 2 that suggested this is going to work well in people, but we have to prove it for real life. That's something different. And then I would say that word promising probably should be used, but you'll often hear people presenting and saying, oh, we have this promising data, but that doesn't predict that it's going to work, or else we wouldn't have to do these trials.
I remember this discussion at Factor 2018 when we had a bioethicist speaking. Oh my gosh, what was his name? I can't remember his name, but Yora Munguru. And this question came up about using the word promising, and it was such an enlightening moment for me, and I think for a lot of people, because here's the long-term, for me, I can talk to the social, emotional kind of repercussions of then not enrolling your child or yourself on it, and then your child or you pass away and your family's left going, or the family's left going, should I have done that trial? That was promising, like that. So it's such a good point, Dr. Janeway, really, really important point to make. And if you hear the word promising, it is worth asking deeper questions. What does that mean? And this audience is so brilliant about picking apart, what does that mean? What does that mean? And I think because we've been in the trenches a long time, but somebody newly diagnosed maybe doesn't know to dig a little deeper on that, or that they can. So such a good point. Max, go ahead.
I have another question from the Q&A. It says, how can patients get access to these drugs if they are not eligible for the trial? How can they know if they have signature 3?
Okay, that's a great question. So one of the things that we struggle with a little bit in designing this trial is there is no kind of standard test for signature 3. There's a reason for that, and it's because signature 3 is only one of the potential things that could predict response to olaparib and ceralasertib. So like you saw, I don't want to go back and pull up the slides, but some of the breast cancer patients who've responded to this combination don't have the signature 3. And so we don't want to limit the enrollment. We want to learn, we want to let everybody in and then learn who is going to respond best. It is possible to test for things like the BRCA mutations and some of these other things. These things are on sort of standard testing that you might get of the tumor, not standard testing. I shouldn't say that. I should say molecular profiling that some people have access to through research studies, for example, or that their physician might send. Then you can find out information about those genes, but it's an incomplete picture. In terms of getting access off the trial, it's an incomplete picture of who will respond, I guess is what I'm saying. In terms of getting access to the drugs not on the trial, you know, I'm really not treating patients with these drugs outside of the clinical trial because I think there are other options that we've already learned can work in that setting, in the relapse setting. And I would use those until I don't have other options. And then I would offer them whatever trials are in my portfolio. Okay. And I think one of the other questions is like, when do you know that it's right for a trial? So in general, this is a very personal decision. Okay. But in general, we have a couple of 2 or 3 sort of chemotherapy, and then there's the multi-targeted kinase inhibitors, or what I call IBs, regorafenib, cabozantinib, sorafenib, that we use in relapsed osteosarcoma. And we use those because we have already trial data that tell us how they might function in that setting. And we tend to use like one chemotherapy regimen, maybe, and maybe one IB or not. And at the time that we're using those, we often will also offer phase 2 trials. And it's really between the physician and the patient to decide, is now the right time for a trial for me, or do I want to use one of these other options where you already have information? Both are okay to do. It's okay to use a trial. It's okay to use one of the other treatments that we've already done a trial on. And so for these medications, I don't think I would access them outside the trial. I think that we're really excited to be doing the trial. You know, when we have the trial results, I hope it works. And I hope then it will become one of those options that you consider outside of a trial. But until then, I probably wouldn't do that. I would look at the trial portfolio that's available to you in your local area.
I have another question from the chat. It says, what questions should be asked of histology test?
Yeah. So I think that says like what tests should be done and what questions should be asked. So in osteosarcoma, I'm not talking about precision medicine or genomics, but or tumor profiling, but it's one of my other passions in osteosarcoma. Let me tell you, this is completely my own personal opinion, not endorsed by anybody, informed by some of the research we've done, but like I'm hoping someday it'll be endorsed more widely so that people can understand really what the standard is in osteosarcoma. So in my personal opinion, I think it's important for patients with osteosarcoma, if their family's interested, to meet with a genetic counselor who can help them understand whether or not to be tested for gene abnormalities that might have made that person at increased risk for osteosarcoma. It's not super common. It's about 5 to 7 out of 100 patients who will have that. But if they have that, it's an important thing to know, I think. And so, but it's a personal decision. So the recommendation is to meet with someone who can sort of, we call a genetic counselor, who can sort of walk you through that decision. In terms of testing the tumor, this one's a little tough for me. So I think at the very least, you should try to look for a way to get the tumor tested that's part of research. And we have ways to do that. And we're hoping to announce at the MIB. We have announced previously at MIB a way to get your tumor tested where the data can be used for research. And I would like to foreshadow that we are hoping to make an announcement about a way to get your tumor tested where you might be able to also hear back about how you are helping us learn more about osteosarcoma through having that tumor testing. Right now, in the research that we've done, getting the tumor tested or profiled, it's extremely interesting. We're learning a ton in terms of like, how do we understand osteosarcoma? Are there osteosarcoma subgroups and things like that? But it's not so helpful for the individual patient and doctor who are trying to make these hard decisions about what treatments to use at relapse. I wish that was different, but osteosarcoma, and there are a lot of reasons for that. You can invite me back to talk about that. I'd be happy to talk about tumor profiling and osteosarcoma, but it's a topic it's a very broad topic. I think it's great to get the tumor tested. I don't think you should shell out money to get it tested. If your insurance company will pay for it and your doctor wants the information, great. But like, it's so far for us and the research we've done, it doesn't provide a quick and easy answer to kind of what the next treatment should be.
Okay. I would love to have a whole osteobites on tumor profiling. It's such an important question. And it's such a topic that we have so many questions about, and yeah, really important. I also want to mention that on MIB Agents website, we have a document called the Testing and Research Directory. And this is a living document that we update regularly. And it has two sections, one where to send your biodata to either inform a personal treatment plan, or the second part to inform research. So this is a really great document that was put together by Christina Iptoma, our Director of Scientific Programs, Richard Gorlick, Corey Painter. Like I think it's underused, but it's really a great piece of a tool in your toolbox sort of thing. It's a great thing. Okay. We need to wrap it up because it's 4 o'clock and we've got to give you back to your patients. So thank you so much, Dr. Janeway, for joining us today on osteobites and making it better all the time for pediatric oncology patients everywhere. And I also want to do just a quick shout out thank you to Dr. Alejandro Sweet Cordero for collaborating with you on this with his lab, which is Genius Lab over at UCSF. It's really cool to have that component to this trial. More information on this and all 80+ osteobites can be found on YouTube, mibagents.org, or your favorite podcast place. If you join us next Thursday, we're going to be speaking with Brenna Carswell. She's a clinical trials navigator. She is going to talk about the clinical trials process, tips for finding all possible trials, and considerations when choosing a trial. So that's going to be something to look forward to. Thanks again to Dr. Janeway, to Max. Well done, brilliant job, Max. I'd like to have you on all the time, every day. And also thank you to the Osteosarcoma Institute for their sponsorship and support of this trial. And thank you for joining us today on Osteobites. Hope to see you next week with Brenna Carswell. In the meantime, please go to our mibagents.org website and grab your seat at Factor. I think we have 9 or 10 seats left. So please go on and grab that. And we'll look forward to seeing you next week with Brenna Carswell and the week after at Factor. Okay, so thanks again, everybody. Have a nice weekend.